A very good evening to all. I welcome you all to the Pedia Talk ECME. Today we have with us one of the eminent speaker, Dr. Barnali Bhattacharya, pediatric consultant and asthma specialist at Children's Clinic, who has converted the science of counseling in childhood asthma into an art, has gifted back a near normal childhood to innumerable asthmatic children, who has 25 years of experience in pediatrics and asthma care, travel across the country training the PGs in pediatrics on childhood asthma. Specialties are pediatric asthma and allergies, newborn counseling, parenting skills, and grooming adolescents to be a better citizen of the world. Not taking much of time, let's hear from Dr. Barnali Bhattacharya on asthma flare-ups. Let's prevent it. Over to you, ma'am.
Thank you so much, Deepa Lakshmi, for that introduction. I wonder from where you picked it up. It sounds like the LinkedIn. So anyway, thank you so much and good evening, ladies and gentlemen. I'm really happy to be with all of you, and thank you, Lupin, for this opportunity. Now, I would say this is that the lungs of my asthmatic children in my practice is actually the heart of the practice. And my mission in life is to gift back a near normal childhood to all the children who are under my care. Now, today I'm going to restrict my talk to asthma flare-ups and let's prevent it. So we all know that the old term that we used to use as acute exacerbation of asthma has now changed to asthma flare-ups. So asthma flare-ups is the new terminology that we use for the severe exacerbation or acute exacerbation. And I'm not going to talk on management of that, not at all. I am going to only focus on let's prevent it. Let's not get there. Why should children under our care have flare-ups? But before I go there, why have I chosen this particular topic? 2020 is a year that we will never forget. But 2020 is also the year when Gina gave us this theme. World Asthma Day, which happens on the first Tuesday in the month of May every year, Gina, which is the Global Initiative for Asthma, gives us a new theme. And this year, the theme was enough asthma deaths. You may say, but do we have deaths with asthma anymore? But I haven't seen it, you might say. You've got it wrong. There are plenty of adults and children across the world who are dying because of this disease. So before I get on to how do you prevent a flare-up, which is the start point of hurtling down to death, may or may not, we need to know some figures, and they are alarming figures. First, let's see the global burden of asthma. It's a common disease, right? We say asthma is the commonest chronic disorder of childhood. Now you see the prevalence of asthma globally. The India contribution is 11.16% of the global asthma, which makes it second rank in the world because of the sheer volume of population that we have. We may say, oh, there are many asthmatics in Australia, New Zealand, Great Britain, but actually India ranks second in the number of asthmatics globally. However, so 11.16% makes us the second as far as asthma deaths go. We contribute nearly half of the global death. 43.63% of deaths because of asthma is contributed by our country. It makes us the first contributor in asthma deaths. And that is not something that we need to be proud of. That is something that we need to pull up our socks and do correct. Now, yes, for pediatricians, I will say it is the adults who contribute much more into this 43.63. Not so many children, but children too, and I will show you the global burden of diseases figures here. I wonder if I can minimize this so that you could see. I wonder if you can see it on your screen. Is that so? The prevalence of under 5, this is the globally, this is what India has, and this is approximately 4%. Okay, 5 to 14 years, this is India and this is the world. This is about 8%. You know, let me just, but look at the deaths. It is nearly double. Like if there is under 5, 4%, the under 5 death is 8%. If the global burden 5 to 14 years is anything between 8%, the death is much more. So meaning we are, even the pediatric population is nearly 12% of the world asthma deaths. And that can be really shameful. So we say 43% of the global asthma deaths is in India and ranks us as 1, but the adult population contributes a lot to it. But that doesn't mean our children are not dying because of asthma. We are pretty high on the global map because nearly 10 to 15% of our children with asthma die annually. With that dismal figure, I now take it that can you and me do something about it? So, what is our goal of asthma management? We want to control the asthma well so that these children grow up like any other children. And when we say current control, we say they should be symptom free by day, their night should be comfortable, there should be no activity limitation, they should have minimal use of relievers, and their lung functions should be maintained. And the future risk, this is where future risk is the flare up. Future risk is the exacerbation, is when they get unstable, they get worsened, they have acute flare ups. This is what we need to work on. And all this affects their lung function. Why am I talking about affecting lung function? That when these children's lung function is, asthmatic child's lung function is jeopardized, as a child who has asthma, he grows up into an adult with much lower lung function than is optimal. And these are these children whose asthma has not got controlled as children are the bad adult asthmatics. They are the ones who have COPD. These are the ones who die, and they are contributing to 50% of the world asthma deaths, and we rank 1. So we don't say that children don't die, and we are not, our things are not so bad. It's the adult asthmatics who are dying, but we have contributed to that burden too. So who are susceptible to asthma flare-ups? Who are the ones who land up with this problem? One are the children who are treatment naive. By treatment naive, I mean the ones who are not treated. So I will just spend a few sentences on the treatment naive. So who are the ones who are treatment naive? The ones who have never been diagnosed as asthma. One fine day they come with the boom attack, and they land up in a hospital emergency, straight into the ICU, and they are diagnosed to have asthma. That's a small group. A big group is children who are asthmatics, but we have not told them that they are asthmatics. And so they are going about just taking reliever medication. That too, not with an inhaler and spacer, but with a nebulizer. So every time that they have, what happens in flare ups? So, asthma is a disease where you have breathlessness, wheeze, cough, shortness of breath, tightness in the chest. So, when all this gets aggravated, that the cough is just not getting relieved, the breathlessness is not settling down, there's tightness, there's shortness of breath, there's tightness, feeling of tightness in the chest. And what do? They just go and they just take the nebulization. Worse still, they have a nebulizer at home, because we have nebulized them every time that they've come with an acute flare up, that they feel this is the magic box, this is what is helping, and they resort to just plain nebulization, and they get well and they land up again. It's happening again and again and again, and one fine day they come boom with a very flare-ups. Can be mild, flare-ups can be moderate, flare-ups can be severe. With those mild, they are coping, but they can land up into severe flare-up. GINA 2019 changed it dramatically. It said that everybody above the age of 5 years, you see, GINA, when it does asthma treatment, it says under 5, it does 6 to 11, and then 11 onwards. More than 5 years, the reliever medication also you need to use inhaled corticosteroids, and it says earlier reliever used to be plain salbutamol, that's beta agonist, or levosalbutamol, and now they said no way, they all need inhaled corticosteroid. There is no role for plain salbutamol. So the rationale that they gave is that even mild asthmatics can land up in a severe flare-up and die. So if you have children who are asthmatics, but they have not been put on controller treatment, please do so, because the treatment knives can land up in flare-ups. Mild asthmatics can also have severe flare-ups. Now, the big talk of mine is going to be, so you have put a child on treatment, but this child has got uncontrolled. And why does this happen? What does this child's situation lead to a susceptibility of flare-up? There are adherence issues, there are trigger issues, there are technique issues, there are comorbidities. So I am now going to take you one by one through them, and I am going to start with adherence first, because even in the best of hands, even in people who have given years of their practice to asthma, and I fall in one of those brackets, being 60, being doing asthma for 30 years, there are still, I have less percentage. They say that nearly 50% of our asthmatics put on treatment non-adherent. Well, I would say that I may have just about 10%, but I do also have non-adherent. But how did my 60% become 10%? Because of what I did, and because of what one needs to be aware of, that where one can go wrong. So I will focus on adherence. Now, I said that asthma is a chronic disease. It's the commonest chronic disorder of childhood. Any chronic disease, to achieve control, because you need to give drugs for a long, long, long time, it is directly proportionate to adherence. Good control is because the patient is adherent. And the patient is adherent because we have gone into all the heads with them. Now, I want to tell you, this is one of my favorite slides when I speak on adherence. Normally, when we talk on asthma, there is so much else that people want to know, and there's so much that we focus on arriving at a diagnosis or giving the right treatment, that we don't have time to focus on adherence. So, because this talk is mainly on preventing flare-ups, I thought, let me introduce you to the concept of the dimensions of adherence. You can get non-adherent because of social and economic reasons. How social reasons? The family is going to their village on a holiday, and they're awkward that their child is an asthmatic and what will people think, and so they do not take that inhaler out in front of everybody. So that becomes like a social issue. Or there is a function in the family, there are relatives at home, and they are not using it because they don't want others to know. Economic. Now, all of us who are using inhaler therapy, and which is the backbone of treatment, and that is the mainstay of asthma management, know that a controller drug is much more expensive than the reliever drug. And time and again, if it's an economically challenged family and they have not bought the controller and it's the end of the month and they've run out of their funds, they've not had the money to buy the controller, and the reliever is there and the reliever is cheap and they are using that. Healthcare system. Healthcare system is that sometimes in the government sector, if they are getting the inhalers. So here I would give an example of the armed forces. So the armed forces does give its patients inhalers, which they can get from the medical store. But sometimes they don't have it. So they say NA, that means not available. NA in the armed forces in the medical store doesn't mean not applicable. It means not available. The guy who is at the pharmacy giving, he will just say, this is not there. Ye NA hai, it's not there. Now the patient will not go and buy it from outside because he's so used to getting free treatment. So he is non-adherent. So when he comes back to you for his follow-up and you say that, what happened to your thing? He says, no, it was not available, so he didn't buy it. Condition related. Now, we said that it's a chronic. That was the graph that I shared. It is a chronic disease. It's not giving drugs only for a short time. It's not drugs just for a month. It is not drugs for 2 months. Even when we are doing a trial of therapy, it's for a minimum of 3 months. But we know that most asthmatics, children, they need the treatment at least for a year. An adolescent, now Gina says that adolescents, they are like adults and that they would need to be given their treatment lifelong. So it's condition related and we need to tell them that. Otherwise they feel, 1 month, 2 months, the child is well, why give it? So it's a chronic disease and they need their treatment for a long time. Therapy related. Most of the controller inhaler right at the beginning is twice a day. It is much later when you step down to the lowest that it becomes OD. So it is twice a day. It's BD. So it is therapy related. And I'll tell you what happens. A school going child, in the morning, the school bus is coming. There's a rush, 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 rush. The morning dose gets missed. And time and again, they will say, yes, I'm giving the dose. If we don't ask them, the first dose is given once the child returns from school, which may be 1 o'clock, 2 o'clock, 3 o'clock, and the night dose is given. But when we say anything that is twice a day, the gap has to be at least 8 hours. So we need to communicate that it is, when it is BD doses, it has to be morning and night. So one of the commonest error in treatment is that children miss the morning dose. And in the lockdown, all the children are waking up late. So their morning, they wake up at 9 o'clock. Their online classes is starting at 10 o'clock. So now there is no bus rush, but they're again missing on this. So they're sitting and they're finishing by 1 o'clock. And then the mother is giving them lunch, and then she realizes, oh, I've not given the morning dose. So we have to communicate that the morning dose is a morning dose. I always say brush and give. And if during these days of lockdown and when we are doing the consultation and they say, this is what's happening, I say set the alarm 15 minutes before time and see that it's given. Patient related is that most of the patient related issues are communication that has failed or their beliefs. Patient related, I'm going to come and I'll tell you that what are the patient related adherence in one of the next slides. So how do we improve it? Adherence, we cannot always blame the patients. It is doctor factors and patient factors. The doctor factors is that when we are doing, we have to know the dimensions of adherence that I've shown you, and to focus on the dimension of adherence, we need to give time. You have to know their economic issues. You have to know, when is this mother also working? Is she also in the morning rushing, cooking, packing the tiffin? Is the father working night shifts and that he is not awake in the morning to help the family giving? So you have to involve into knowing the family dynamics, which can cause non-adherence. You have to know, is the family going to the village and so you have to say, look, you need to give the treatment. Don't worry what people say. It's your child. When your child has an acute flare up, they are not going to come and help you. They are not going to foot your bill. They at the moment are just going to sympathize with you, not even empathize with you. So this is your child and he needs the treatment and you need to give it. So you need to spend time, and when you spend time, it is the success that you meet. Now let me tell you the patient factors. Sometimes it's unintentional. They don't even realize that they made a mistake. That very much depends on their ability, that they haven't understood, right? They think it is the reliever medication that helps. So maybe this is the good inhaler, because this is what I've been told to use when there is a problem. So again, we've gone wrong. So when we are introducing treatment, we need to tell them this is your main medicine and this is your controller treatment. The reliever is like a push start. The reliever is when you land up with a flare up, but the reliever is not what you should be resorting to. And resources, like I told you, that it is the expensive inhaler, the controller, and we need to tell them that, if it's somebody who's economically challenged sitting across you, you need to tell them, please buy it at the beginning of the month. So these are practical patient barriers to adherence. Now there are intentional non-adherence. This is totally on patients' beliefs and motivation. Beliefs is, my child is okay, why should I use it? This is very much in the so-called educated and the Google patients who feel, my child is okay now. Now there are no symptoms. My child initially used to have a recurrent cough with variability, used to have breathlessness, wheeze. Now 2-3 months, it's okay, so why must I use it? So also, when I say motivations, here the adolescent come in. Intentional non-adherence is time and again parents who feel my child is good, why should I give it? It is also the adolescent who feel I don't need it. I'm all good now. I don't need that inhaler anymore. So you need to motivate them. You need to tell them that, look, I'm preserving it for you so your lung functions so that you can be a strapping, healthy adult to be able to do everything, not miss school, not miss exams, be able to play games, participate in competitive sports. And so these are patient's perceptual barriers which you need to work on. Okay? So, how do we get parents to be adherent? One is follow ups. Some of my colleagues feel that they are kind to their parents and they'll call them even the first follow up after a month and maybe the second follow up after 3 months. And I feel it just doesn't work. My first follow up is within a week. The second follow up may be fortnight. So first 2 months I might do fortnightly and then make it up to 1 month when I'm seeing adherence is good. When I'm seeing that the counter is tallying with the date that they put on the carton, because you can find out, right? Like if the inhaler has a counting chamber and if say you started on the 11th of October and today is the 11th of November, and if it's BD, 60 doses should have moved. If only 30 has moved, you can catch the patient and say, what happened? And then they'll say, oh, well, he was having morning exams and we didn't. Or they might say that my husband was not there in the morning. So you will be able to find out. And sometimes when in the beginning, when you start treatment and people give up on treatment because they feel that we need to discuss the inhaled corticosteroids once again. So the follow-ups have to be close. Then step down. What does step down mean? It is like dangling that carrot, because I always tell my parents that you need to come for regular follow-ups because you see you are so resistant to starting this child on treatment. But he's not going to be on this Vidusnite 200 BD continuously. I'm going to get it down to 100 BD and then 100 OD. And how does this happen? If we do follow-ups, if I need to get to know your level of control, if I see that there are no acute flare-ups and that you can cope better, that's the way. So stepping down is an important carrot that you dangle. We also need to tell them about the risk of remodeling, the loss of lung functions. So if you are doing regular spirometry, it is very easy to tell them. And this that I showed you figure right in the beginning, that 43% of global asthma death, children and adults put together, is in India, and 15% is pediatrics. So a lot of adult asthmatics is what we have contributed to because we've not handled them properly and we've jeopardized their lung functions. Peak flow is an excellent objective tool to show improvement. Peak flow is a very good tool for adherence. Hence, when initially say when you're starting a child on treatment and the peak flow reading is 100, and then say after 4 months of treatment the child from 100 has come up to 160, has gone up to 180, and you've told them right at the beginning that 180 is my target, they feel, see, this has helped. You've objectively shown them, and gold standard is spirometry, but if you're not doing it, at least as a follow-up tool, if you show them improvement on peak flow, they will adhere. See that they maintain an asthma diary. In the asthma diary, let them draw the columns of various things of control, that is daytime symptoms, night, limitation of activity and reliever use, and encourage them and reward them. Don't shame your parents if they have done something wrong. Yes, but I'm telling you this from personal experience. Earlier I used to come down like a ton of bricks if they were non-adherent. And one father said that I was so scared to come to you because I didn't give it because I lost my job and I could not buy the controller treatment. And but I didn't know what to do. So I was actually very ashamed of myself, that maybe if I had kept myself open and didn't come down so strongly, if they miss, yes, I am rigid because that's the way I get them to adhere. But you should not scare them so much that they get scared to come to you if they are non-adherent. Now, from adherence, so I have discussed adherence with you. Now I come to you with triggers. One of the biggest problems with flare ups is a child who's cruising well. So there is a saying that it is just not the children who are uncontrolled who get into flare ups. Even children who are controlled can land up in acute flare ups. And who are those who have been suddenly exposed to triggers? This is a beautiful slide, and here I'm going to take you through the triggers and also later discuss some triggers in details. This is the house dust mite. This is also the moles. So you see, house dust mites. This child is also sneezing. House dust mites is in old books. It is in your mattress. It is in your upholstery. It is in your carpets. It's in the books which may be kept there, and a child is just opening, or a father is opening the encyclopedia and saying, I won't teach him online, but I'll open a book. There you go. From the window, you're also seeing the clouds. Rainy season, seasonal change can bring up a lot of flare up. You are seeing now the season is changing, into winter, and we are seeing a little bit of mild flare ups. Season changing into rain. So you have to know which is your child's flare up season. That time you might need to increase the controller medicine maybe 15 days before the season and take it through the season, carry on like that. And maybe after the season has changed, step down. Similarly, when we are stepping down treatment, never step down during season change or never step down during monsoons, which is a trigger time. Why is the cloud cover a bad thing? Like they say that around us, there are positive and negative charges in the atmosphere, and it's the negative charges which are beneficial. And when there is a cloud cover, the cloud also has positive and negative charge, and at the bottom of the cloud is the positive charge, and it attracts all the negative charge from the environment up to it. So we are left with predominantly a positive charge around us, and that is why during the cloudy time that you hear a lot of children having a little bit of a flare up. So if it's a child who during a cloudy season you have to tell the parents that they might need to use a temporary step up, or that if there is a flare up coming in, they have to start the first aid treatment fast and quick. Now you're seeing here, there's a cat up here and there's a dog up here. So animal dander, pets. Why is cat up here? The cat is much more allergenic than the dog. But if there is a pet already there at home, should you tell them to get rid of the pet? The answer is no. There are so many triggers. It may not be the pet. And remember that stress is a very big factor. And stress itself can bring on a trigger. When I say stress, it can be examination, it can be separation in the family, or just a swing of emotions that even a birthday can bring on an attack. Like, I've had children who every birthday they have a mild flare up. So we have to be involved to know. Here, raising dust can be a trigger. So it is better to do wet mopping and not doing the dusting when the child is in the room. Now, you see smoke of any kind, smoke. I'll show you the smokes of the other kind which can trigger. You see many a time cooking spices can bring on an attack. Here, this again, deodorants. This is a mother spraying. Sometimes it happened to me just yesterday. A child who was admitted, I think 2 months back, into an ICU for acute flare up, and was told about all the triggers. But this 12-year-old was meeting his friends, and he happened to use not just his father's deo, but the mother is a beautician and strong perfumes, and came down with the flare up. We were trying to zero down what brought him, and then he owned up that I was all good and this is what I did, and he landed up with a flare up. Tobacco smoke. Smoking is something which has whole lot of problems, but tobacco smoke is one of the worst thing for an asthmatics. Here there's a child running. Exercise is the only trigger that we do not avoid. Exercise is a trigger that every child should be playing, but with correct treatment, they overcome their asthma. And please do not tell any of your children not to play. A lot of mothers say, I don't like to send my child for games because he comes breathless. To them, I say we manage asthma such that the child is not breathless. Now, why is there this car? Traffic pollution, traffic related air pollution is one of the biggest issues of asthma. Also mentioned in Gina that children who stay in homes which is less than 75 meters from a main road have a very high chance of being asthmatics. And also the diesel emission particles make pollens of trees 200 times more allergenic. So that itself can also cause asthma. And this is industrial pollution. Children who stay, their homes are close to an industry which is polluting can also be. So we have to know about all these triggers to be able to guide them correctly, because a controlled asthmatic can also become unstable because of trigger. Here I will show you some things which I want you to be aware of. Mosquito coil. One mosquito coil is equivalent to smoking 100 cigarettes. And this is something that you need to be aware of. Time and again, it has happened that a family has gone to an outdoor restaurant, to have a dinner, and they put mosquito coil in the bottom of the table, not one but two, because there's so much of, and by night the child has started having a flare up. You have to tell them. Indoor fungus. It is very, very important during the rains. If there is dampness and if there is fungus, it is one of the biggest trigger of asthma. And while I'm talking about mosquito coil, I also want to tell you, no, I'll come to this later, is agarbattis. Agarbattis, the smoke and the strong smell can also trigger, problems. So all my asthmatics and allergic rhinitis patients, I tell them no agarbattis at home, and no mosquito coil at home, and you should look around dampness. I chose this particular slide. Diwali is just a few days away. Though it says that Diwali and fireworks only does contributes a short thing to the pollution, but this is something that you can do. This is something that you can prevent. All of you, this week I've had two boys who have come, one with a mild flare up and one with a moderate flare up, because both these boys, I mean, shame on the family, shame on the society that they have gone down to burst fireworks even a week before Diwali. I don't know why they shouldn't ban it. Some states are, and you might think I'm coming on strong, but this is something that we can prevent. And I will show you from our own city, Chest Research Foundation, which now does not exist, and we have CREST instead. A study was done, and I'm very, very aware of this study, is that before Diwali, during Diwali, and after Diwali, the sulfur dioxide levels during Diwali had reached 200 times more than the safety limits of WHO. It contributes so much to the air pollution, and it can cause a flare up. I'm sure you have seen. So, we as pediatricians, our children adore us, right? The families who are under our care, they really look up to us. So if you could take up the thing of no fireworks during Diwali, I'm sure you can change a whole generation of children. Please do so. Now I've discussed adherence in great details to prevent flare-ups. I've discussed triggers in details, because even a controlled asthmatic can have flare-up. And now I'm coming to techniques. One of the big issues when I am referred asthmatics who are just not achieving control, and so they've reached a pediatrician with a flare up and they have been referred, I see that one of the big issues is technique. In technique, one is appropriate device. Appropriate device has to be age specific. You cannot have a 10-year-old with a spacer and a mask. That mask is increasing the dead space. But sometimes when this child was 3 years old, somebody had prescribed a spacer with a mask and they're continuing to use that. Sometimes they use an inhaler with just the mask. Wrong. Sometimes they are not using any spacer because the child is so smart and he can do the inhaler straight, and so there is no spacer being used. So children more than 4 years to adults, the ideal device is MDI with a spacer. There is no role of MDI without spacer. There is no role for MDI with just a mask. And there is absolutely no this thing of the spacer with a mask for a child more than 4 years. The moment they can do it without the mask, take them off the mask. Correct technique. We have to know the correct technique to tell them where they go wrong. One of the major thing is they're not shaking. And the canister has just 1 ml of the drug and 14 ml is everything else, propellant, surfactant, preservative. So if they are not shaking, they're only getting propellant. And they can land up in acute flare-up. And you're saying, I'm not achieving control, and you're increasing the controller medication. So you need to know the correct technique, and you have to tell them what is every step of the technique and recheck at every visit. Because sometimes parents get lackadaisical and they do not do it correctly. So at every step, you remember a faulty technique can land up your child into flare up. Now, Addressing comorbids. Asthma, uncontrolled asthma, leads to flare-ups, and one of the reason that the asthmatic child could be uncontrolled is because you've not identified the comorbid condition, which could be allergic rhinitis. 70% to 80% of our asthmatics have a concomitant allergic rhinitis. It's the United Airways. And if you're not going to manage the allergic rhinitis, your asthma is not going to get controlled. And if the trigger is such where the allergic rhinitis gets much worse, especially Diwali, especially rains, especially molds, we can land up in a flare up. A gastroesophageal reflux disease, and obesity. An obese asthmatic is a very difficult to control asthmatic. A lot of the flare-ups are the obese asthmatics. So we need to be aware of the comorbids. Asthma action plan is what all of us, you and me, should be giving all our parents. They should know what's the present treatment. They should know what's the plan and what are we looking at the control. We need to tell them about all the trigger avoidance. During the last 2 weeks, I'm telling everybody no fireworks, no agarbatti during the Lakshmi Puja. We have to make them, if last 2 months I've been focusing on the molds, you have to tell them everything. You have to teach them recognition of a flare up. You have to say that if your child's cough is not going, this child is breathing rapidly, if this child is breathless, even at rest, this is flare up. You have to tell them the home management. You have to tell them that they need to give the reliever medication, 4 to 10 puffs different depending on the age of the child, maybe 3 times in a spell of 1 hour. And if that is not happening, then they need to take the child to the hospital or to the clinic. But they shouldn't panic. In that panic, they lose time. If this is happening, the first thing that they should do is give the MDI with the spacer and the reliever medication in the right way. And tell them that they shouldn't be resorting to the nebulizer, because the nebulizer is only to be used with the oxygen, because that nebulization takes wrong. The nebulizer might be growing fungus, and in nebulizing and they might have a VQ mismatch and come with a much worse state. So if they've recognized a flare up, they should be using the reliever medication. If the child settles, yes, they can come to the doctor the next day and say, this is what's happened. If the child doesn't settle, then they need to, but the asthma action plan has to be told. If they have a home monitoring like a peak flow meter, they should be doing that. And you should tell them that if it should always be 80% and above. If it is anything between 50 to 80%, that means there is a flare up and you should start using the reliever. And if it is less than 50%, you need to reach out, but we need to communicate. So what are the effects of asthma flare-ups? Asthma flare-ups causes morbidity, it causes mortality. What is the morbidity? It has impaired quality of life. There is a fear that this might happen at any time. So there is a psychological thing that once there is a flare-up, they always feel this might happen again. I've had one of my children who had a flare-up a year back, and the child came with a mild flare-up just a week back, because of renovations at home. This is again something that in the trigger around Diwali, there's a lot of renovation, and they thought all is good. And what he told me that, so this time they managed to give the reliever medication and he was fine. But what this child, he's 11-year-old, told me, he says, Auntie, I remember from last year, and I was so afraid that I might be admitted again. And I said, don't worry, you won't be. I was worried that stress might induce an attack. So psychological pressure, economic impact. An admission costs so much. They miss out on school days because of flare-ups. Asthma is the commonest cause of school absenteeism in children according to WHO. They have to be rushed to emergency visits, and emergency visits are that much more expensive and stressful. Many a time the senior doctor is also not there. They might need hospitalization. And ladies and gentlemen, asthma can kill. We need to be aware of that. So my last slide is, this is the global asthma mortality. Where the mortality is more, it balloons more. Look at where we are in India. We have the world's 12% of asthma prevalence, but we have nearly 43% of the global mortality. You and me can change that. So let's join hands. And how can we do that? We have to be aware of asthma flare-ups, and we have to prevent it. Because the first step of reducing that mortality is recognizing asthma flare-ups and preventing them. And we can prevent it by knowing it ourselves and educating our families about it. Thank you so much for a patient hearing. And I will now stop sharing my screen. And if there are any questions, I think I have stuck myself to the time. I was told to speak for anything between 40 to 50 minutes, and I think I've spoken for 50 minutes. And if there are any questions, I'll be happy to take so.
Thank you, ma'am. We have a few of questions for you, and it was a quite delightful session to all of us.
Thank you.
So I'll just take one by one, and then you can address the same. There's a first question to us from Dr. Ravi from Aurangabad. He mentions his one of his concern that the parents who visit his clinic are not ready to start the inhalation therapy, and which forces him to start with the oral therapy. How should he take a step to convince them to start with the inhalation therapy?
Ravi, Dr. Ravi from Aurangabad, it's the question that you asked is actually closest to my heart, because this is the first hurdle. If you drop it, there is no managing asthma well. So first thing, Dr. Ravi, you need to be convinced yourself. If you are going to resort to oral treatment, and by oral treatment, I would think Montelukast, then you are being unfair to the asthmatic. So what you have to tell them is that, you have to explain to them about the disease. You have to tell them that asthma is a disease of the airway, and asthma is a chronic disease. For asthma, we need to give treatment for a long time. And because it's a part of a disease which can be targeted, just the way if I have a skin issue, I would use an ointment. If I have an eye issue, I would use an eye drop. So since I can target it, I use the breath tubes to show them. I said, see, look, there is this chronic redness and swelling. They may not understand inflammation. So you said there is a chronic and redness, and so I need it to use for a long time. And this can be targeted best by inhalation medicine because it is there. We need less drug because it is there. It acts quicker, and because it is there, the side effect is much less. And I would then probably pick up a syrup of a salbutamol and say that, look, this is 2 milligram in 5 ml, and this is just 100 microgram. So it is 2000 microgram versus 100 microgram. Then when you are taking oral medication, it is going to all the body system. You need it just there. And if you are, Dr. Ravi, a Montelukast believer, I want to tell you something, is that Montelukast acts only in the leukotriene pathway, whereas the inhaled corticosteroid acts in all the other inflammatory cascade pathway. And I explain to parents like this is that if I have to give marks to my asthma medication, then 9.5 out of 10 is the inhaled corticosteroids and zero point 0.5 is the Montelukast. And I also wish to tell you the GINA 2020 Montelukast has come under huge scanner now, and they feel it has neuropsychological effects in adults as well as in children. So be very guarded about using it, and please be convinced yourself, and please give them time, and please, all the knowledge that you have, transfer it to them, and believe me, they will listen to you, provided you are convinced and you convince them with conviction and with time and with knowledge.
Thank you, ma'am. There's a next question from Dr. Ankit from Lucknow. He says in management of allergic rhinitis overlap asthma, how would he go in the management of the same?
Okay, Dr. Ankit, again, a very good question. Now, allergic rhinitis is a very strong comorbid. Now, allergic rhinitis can again be graded, into mild and a moderate to severe form. Now, if it is a very mild one, which is rare, those mild are, seasonal, they are less than, so it goes by, less than 4 days in a week, in a month. And so if you have a child who is sneezing, blocking, so they are runners and blockers, you need to most certainly use intranasal steroids. And in the intranasal steroids, the two molecules which are very good is mometazone and fluticasone furoate. There is a fluticasone propionate also, but the better drug is fluticasone furoate. Here I would like to say, please, 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 with folded hands, do not use the Montelukast and antihistaminic combination. A lot of pharmaceuticals have it, and they have it because it's economically viable. Because you are using it. If we stop using it, they will find less prescribers. If you need to use an antihistaminic, use it separately for 10 days or 2 weeks, and you use your intranasal steroids. Here you might have a role of Montelukast. If there is allergic rhinitis along with asthma, those are the situations where Montelukast might have a role. And when you use Montelukast, it's not for 10 days or 2 weeks. It is for a period of 3 months. But in intranasal steroids are very, very valuable drug, and intranasal steroids had to be used. There is a technique of giving it, since you asked such a good question, that it is not to be given lying down like a drop. People have to be sitting, and the nozzle has to put sideways, and the squirting has to be done. And intranasal corticosteroids are cleared for more than 2 years of age, and you can choose a mometazone or fluticasone furoate depending on what you believe in.
Thank you, ma'am. There is a one question from Dr. Nandini from Hyderabad. She asks, in which age group of patients do you recommend spirometry?
And is it Dr. Nandini or Dr. Nalini?
It seems like Nandini.
Nandini.
Yeah.
Okay. Doctor from Hyderabad, Deepa Lakshmi is not sure whether you're Nandini or Nalini. So it is, I, in my clinic, do spirometry for every child above the age of 5 years. And that is the global recommendation. And that is what we should do. Before putting a child on any controller therapy, we should make an attempt of doing spirometry. Now, in 5 to 6 years of age, some of them may not be able to do it. Beyond 6 years of age, they all can do it. So I would say that beyond 6 years, you should definitely do it for all. But if the doctor has the skill, then I think even 5 years and beyond, you can do spirometry. But it is the gold standard in achieving objective diagnosis of asthma and should be done.
Thank you, ma'am. There's one more question from Dr. Mehta, who is from Ahmedabad. He says, what is your opinion on uses of omalizumab as there's in management of severe asthma, and how long would you recommend this?
Dr. Mehta from Ahmedabad with folded hands, I would say 30 years of asthma. I have no experience of omalizumab. And when I ask a lot of my pediatric colleagues, meaning people who are in this for as long as me, the answer is the same, because the severe phenotype is actually not there in India. And most of our asthmatics, the pediatric age group, are the eosinophilic variety, and they respond extremely well to inhaled corticosteroids. And for theoretical answering of yours, what they say is that if omalizumab is used, it has to be at least used for 2 years, and it is extremely, extremely, extremely expensive. And two of the colleagues who are belong to very prestigious institutes, they said that in 2 months time, first 2 months they came, and after that they were lost to follow up completely. So the recommendation is at least for a period of 2 years, but I have no personal experience because I have not used it.
Thank you, ma'am. So, ma'am, there is one more question from Mumbai. Dr. Kunal talks about nebulization therapy is from Mumbai, Thane. He says that nebulization therapy is well accepted by the parents, and it's also easy as comparison to users of MDI. So, how should I go for the management of asthma in such a scenario?
Dr. Kunal, very smart question, and because now let me ask you, how did the parents get introduced to a nebulizer? By you, right? And why did you use it? Because the child came with cough and you thought would respond to a bronchodilator, right? And suppose you in your clinic use MDI and spacer, which I do, when they come for their asthma management treatment knife, and I'm doing a spirometry and I'm doing their bronchodilator reversibility, or they've come with a mild flare up and I'm using a MDI and reliever vis-a-vis a nebulizer. So my parents believe that this is as good. But if you use a nebulizer, now I've done a study, and 30% of the children referred to me by pediatrician for uncontrolled asthma have nebulizer at home. Grim. Of these, 50% have been prescribed by doctors. That is a shame. And the 50% have decided to buy on their own. Why? Because the doctor, anyway, when we go to the clinic, they nebulize morning, evening. So the chemists have told us we can buy the nebulizer and we can give it at home. Now, if you think it is easy to give the nebulizer, you're wrong. To nebulize the 2 to 3 ml, 3 ml is the ideal solution to be nebulized. It takes 10 minutes. To give the MDI and spacer takes 2 minutes. 10 minutes versus 2 minutes. So it is your ability to tell parents that that is quicker, this is more effective. Now, something that we need to know, in the 2 milligram of salbutamol that you are nebulizing, most of it gets deposited in the oropharynx. A very small percentage reaches the airway. Okay? When you are giving with an MDI and spacer, most of it reaches the airway. When you are depositing so much in the oropharynx, there is a lot of side effects. So a child nebulized with a bronchodilator, a salbutamol, has irritability, tremors, palpitation versus a child who is given with a MDI and spacer. So the rot started with us. We started using the nebulizer and our parents started believing in it. So I very strongly believe in the misuse of nebulizer. I have a YouTube channel on Dr. Barnali Bhattacharya, and there is a talk on misuse of nebulizer. I tell all my, so there's a little talk on it, Dr. Kunal, and you can hear that. It may be easier for you to convince your parents. And when I have parents who've come to me with a nebulizer at home in block capital, I say no home nebulizer, so that the referring doctor sees it and knows that what he did was not right. Sometimes I call them up and I say, if you use the MDI and spacer and tell them, and you use it in your clinic, they will see it is as good. So we made the mistake. It is our responsibility to correct it. And I hope you will convince, and you will hear the talk, and you will convince first yourself, and then you will convince the parents under your care. It is something really wrong. And let me tell you, we lose children because there's a VQ mismatch. They've had flare up and they keep nebulizing. When they come, they're hypoxic. And these are the children who are not, they may have started with a mild to moderate flare up, but they land up in severe situation because of a VQ mismatch. I've had children reported from after postmortem that they died because of fungal pneumonia, because of frequent nebulizing. There was fungus that was growing in the tubing. Do you know how to clean a nebulizer tubing? Most of us don't even maintain it. At home, they never have cleaned the nebulizer tubing. So it is something which is very, very harmful. And so please don't do it. My request.
Thank you, ma'am. There is one question from Dr. Mukesh from Bangalore. He says, how should he manage the viral wheeze?
How should we manage the
viral wheeze?
Okay. If it is just a viral associated wheeze, now, if it is, here, you can use a bronchodilator, but by the inhaled route, not the oral route. If this child responds to it, it could also be a first episode of a young child presenting with asthma. So whenever a viral wheeze happens, we have to first convey to the parents that the wheeze is maybe because of turbulence in the pathway of the air. So we will see if this child responds to this. If there is no response, say in bronchiolitis, there is no response, please document it. Then you have to just counsel them that it is self-limiting. So they have to be humidified well. If this child with viral associated wheeze is hypoxic, then they might require hospitalization for oxygen. So a viral associated wheeze with hypoxia would need oxygen. A viral associated wheeze without any hypoxia just needs counseling and humidification. And so they have to be we have to tell them that they have to give enough fluids orally. If this child is not accepting fluids, then these are the children who are admitted by give judicious IV fluids, to monitor their oxygen, to give them inhaled bronchodilator, just a trial to see if there is a response. If there is a response, please document it. If this happens again and again, this could be pointing towards a probability of asthma in the under 5 in the GINA boxes where they have, the second box, and this child might then warrant a trial of inhaled corticosteroid. I hope I've answered your question, Dr. Mukesh.
Ma'am, there's a long question from Dr. Anu. She's from Trivandrum. The question is, in the management of an uncontrolled asthma, should I start with the ICS inhaled corticosteroids, or should I start with a combination therapy of ICS plus LABA? And for how long should I prefer it? And what should be the tapering dose?
A brilliant question. Now, I would want to know is that when you say uncontrolled asthma, you have to know, why is it uncontrolled? Is the technique fine? Why should you escalate the dose if the technique may be incorrect? You are giving budesonide 200, 1 puff twice, but the child is not giving it correctly. So before you escalate anything, you have to first know that is the technique right. Now, you might say that, no, ma'am, this is a treatment naive child and I am initiating treatment. So in that case, should I be using plain ICS or ICS LABA? Then I would ask you, how old is your child and what is the step in which this child is. So you go again into the GINA boxes. So if this child is more than 6 years of age, and if this child is, say, step 3, that, is this child is having nocturnal symptoms, is leaving reliever frequently, is having limitation of activity, the triggers are many, and it's just not a viral thing, yes, you are completely justified in starting this child on ICS and LABA, and I would do so. So, in choosing your controller therapy, it depends on the age of the child and the step of the disease. So you have to first have this in your mind. And if this is a child who's uncontrolled but already on treatment, then before you escalate treatment, you have to first find out, is the technique fine and is the adherence good? If the technique and the adherence is an issue, then no need to escalate. Treatment naive on the step and on at the age of child. Now you said, how do I step down? If your child has achieved good treatment, then you can step down by 50%. So if your child is on formoterol budesonide 200 BD and you've achieved good control, you can step down by 25 or you can step down by 50. I step down by 50%. So I would then bring down this child to formoterol budesonide 100 BD and counsel the parents that if this child is not holding good, I might need to go back again. Call this child when you've stepped down for a closer follow-up, say every 2 weeks. And if they are no more on home monitoring, tell them this may be a good time to again start the breathometer, the peak flow monitoring. Then the other thing is that do not step down when the season is bad, the season is changing, it is Diwali time, or in the north it is Holi time, that there are environmental triggers or there is an impending stress like examination. Don't step down when there is there is a function, there is weather issues, or it's the child's season change thing, or there is travel. So plan step down again accordingly. So step down, say, then if you've got it down to formoterol budesonide 100 BD, then your next step down would be budesonide 100 1 BD. Then your final would be budesonide 100 1 OD. Now, if this is an adolescent, now they say adolescents are like adults and might need treatment for a very long time, if not lifelong. So your question, though sounded simple, depends on age and depends on what is the severity of disease, and also is it a treatment naive for the first time you're putting on treatment, or is this a child who's on treatment but is technique wrong and is non-adherent, and you're stepping up. But a great question, and I must thank all of you who sent questions, and the questions were excellent.
Thank you, ma'am. These were the questions and others which you have answered through the other questions to the audience. Thank you for your session. I would hand over session to Abhishek. Abhishek, over to you.
Wow, truly a mesmerizing session, ma'am. Uh, I mean, one of the best question and answer session I would have seen. So I, on behalf of Lupin and entire folks, we extend a very hearty vote of thanks to you, ma'am, for taking your important time and sharing the platform with us. Thank you very much for gracing your crucial work on the above topic and sharing your opinions and findings on the same. Thank you
Thank you
very much,
very
ma'am,
much for
for
having me.
accepting the
It
invitation.
is not important time. Important time was this sharing, my experience, and I'm grateful for the opportunity given. Thank you.
Thank you so much.
Thank you so much, ma'am.
Thank you, ma'am.
Thank
Thank
you.
you, ma'am.
Thank you. Good night, and wish you a very happy Diwali.
Thank you. Happy Diwali
Without,
to you.
Diwali to
without
you.
Please do
crackers.
not burst crackers. Please do not use
Without crackers.
Sanbatti and spread the awareness. Okay?
Thank you, ma'am. Thank
Thank
you.
Sure,
you.
ma'am.
Thank you,
Thank you.
ma'am.
Bye
Thanks.
bye. See you all
Bye,
again.
ma'am.
Bye.
Bye-bye.
Thank you. Bye.